So what are the goals of surgery? Well, as I said before, we want to remove the part of the brain that's essential part of the circuit involved with causing seizures, or that is causing seizures itself. And our goal is seizure freedom. We want to reduce that risk of accidental death or SUDEP to as close to zero as we can. As I said before, only about 20 to 30% of those that are seizure-free after surgery can be completely off medications. But a lot of the time we're able to reduce the dosing on the medications and therefore reduce some of the side effects. And of course we don't want to hurt the patient. So first we have to figure out if the patient is a good candidate for surgery. Do they have temporal lobe epilepsy, or are there seizures coming from some other part of the brain? And I talked about this a little bit. This is admitting the patient to the hospital, to the epilepsy monitoring unit, and recording seizures on video EEG. That's called phase 1. In this situation, we sometimes do things to actually make the patients have seizures, like sleep deprive them or drop their medications. We generally get an MRI, if they can get it, to look for a structural abnormality in the brain that might be causing the seizures. And we do neuropsychological testing, which is like doing puzzles and trying to figure out if there is a specific part of the brain that isn't working well, and that might be an indication that that part of the brain is involved in the seizures. And then there are a number of other specialized tests that we and other groups do to either confirm or develop other theories as to where the seizures are coming from. And some patients are really straightforward. There's a clear abnormality on the imaging, as you can see here with the arrow. That inner part of the temporal lobe, called the hippocampus, is very bright in the lower panel, and it's a little bit smaller than on the other side. And sometimes the seizure seems to be like a typical temporal lobe seizure. The video EEG all works, and neuropsychological testing shows that that part of the brain isn't working very well. And those patients you can take to surgery and they're going to do very well. In some series, you're going to get 80% seizure freedom rates. Other patients are not quite so straightforward. So either the data is conflicting, the neuropsychological data points to one area and the MRI to the other. Sometimes it's not 100% clear which temporal lobe the seizures are coming from. Or it's sometimes not straightforward if the seizures seem to be coming from outside the temporal lobe. And at most busy and expert epilepsy centers like ours, more than 20% of patients are not that straightforward, but we can still help. And the way we do that is by getting past all the skull and the muscles at the side of the head that interfere with our recording and recording directly from the brain. So this is called phase 2, and here's an example of this. This is not new. We've been doing this since the late 1930s in North America. And what we do is we do a standard operation where we take bone off and we put electrodes directly on the surface of the brain. And then the patient goes back to the epilepsy monitoring unit, and we hook up those electrodes and we wait for the patient to have seizures, and then we can record much better where they're exactly coming from. This is, not surprisingly, very expensive, and unfortunately there are risks to this procedure that are not insignificant. The main thing is that you've got wires coming out of the patient's head, so that there's a risk of infection. That's about 2 to 3%. There's a risk of bleeding. There's a risk of increased pressure because of how large these electrodes are. And the complications rate goes up based on how many electrodes you need to put in there to figure out what's going on and how long you need to leave them in to record seizures. So we've tried very hard, along with a number of other groups, to try and reduce these risks with a different technique called stereotactic EEG. And with this, instead of doing a large bone flap where we take bone off and put these grids and strip electrodes on the surface of the brain, we take these very, very small electrodes and place them directly in the brain through a very small hole. And the risks seem to be much, much lower. In a large German series, there's about a 6% risk of serious complications, and a more recent series from the Cleveland Clinic shows that there are are really very low risk. They had a 2% risk of hemorrhage without any consequences, of bleeding without any consequences. And the other nice thing about this is if the electrodes or the site gets infected, you can take it out. You don't lose that bone flap that you had to take off for the grizz and strips. It also offers advantages that you can sample parts of the brain that are deeper much more easily and much more safely. Now this too is an old technique that's been around since the mid-70s, but what's really changed is that with MRI and robotics, we can make sure that we avoid blood vessels, and we can place a lot of these electrodes very quickly and very safely. And so we were actually the third center in the US to purchase one of these ROSA robots. And this can switch, you can do the trajectory planning the night before and put in the electrode, step on a pedal, it goes to the next trajectory. And this reduces the length of the surgery to place a large number of electrodes from 8 hours to about an hour and a half.